Good morning, everyone. It's a pleasure to be here with you. As was mentioned, my name is Ashby Wolfe. I'm a family physician, and I'm currently the Regional Chief Medical Officer for CMS Seattle, as well as CMS San Francisco. For those of you who may remember Dr. Nancy Fisher, my colleague who retired in June of last year, I've stepped in to support the Seattle office as well as the San Francisco office. Nancy and I worked together quite closely for many years, and so it was sort of a natural fit for me to step in. But if I haven't met you yet, the reason is I stepped into Nancy's role and then went out on maternity leave. So I'm really just back for a couple of months and really excited to be here and to engage with you all in person after the challenging years that we've had with COVID. So today, my hope is to be able to speak to you, give you a general overview of how CMS policies have changed and what's to come in the wake of the COVID-19 public health emergency, and specifically focusing on some timeline and telehealth policy. We're also going to talk a little bit about some proposed policies, things that are not yet finalized, but things that have been proposed this summer to affect reimbursement of telehealth in the coming calendar year. And hopefully, while this is not a completely comprehensive review, hopefully it will give you some key items to keep in mind and some resources that will enable you to stay up to date over time. So of course, as you all know, as COVID was really surging across the country in the early part of 2020, CMS leveraged its authorities to provide for waivers of our existing regulations, flexibilities that allowed our clinicians to provide care and beneficiaries to access care in a way that traditionally they cannot under our existing regulatory structure. And this slide just sort of showcases as an example telehealth policies that were in place, care by phone, which allowed beneficiaries to get care in a different way, and some specific waivers that were unique, such as the Acute Hospital Care at Home initiative. Now, with the ending of the COVID-19 public health emergency on May 11th, the combination of waivers and flexibilities that existed, many of them came to an end because they really were intended to simply allow for flexibility during a national emergency. So things like our emergency interim regulations, our so-called blanket waivers that allowed clinicians from across all different provider types to provide care in different ways, and of course all of our guidance, most of that has now ended. However, that doesn't mean that CMS hasn't learned a lot from our experience with partnering with clinicians and facilities during the public health emergency, and those lessons learned have been applied to some of the proposed policies that I'm going to speak to today. This slide, while a little bit difficult to see from the back, is a timeline of some of the existing flexibilities and as we move through this year, how those flexibilities end. As you can see on the left-hand side, May 11th, that's when the public health emergency for COVID was declared over. That ended a number of flexibilities that had been in place for about 3 years. For example, Medicare coverage for over-the-counter COVID-19 testing. That no longer is covered because the public health emergency has ended. People can still obtain COVID-19 tests over the counter, but they must pay for them as opposed to Medicare covering it. In addition, things such as enforcement discretion allowing Medicare beneficiaries to receive vaccinations in skilled nursing facilities and having it be billed differently during the public health emergency. Now all of that has to be bundled into the usual way that vaccines are provided and then billed for in skilled nursing facilities. So just a couple of examples of things that really were appropriate to end with the ending of the public health emergency. However, as you can see, there are a number of other flexibilities that are continued or have temporary extensions until a time definite. Some of those are the telehealth flexibilities, which I'm going to speak to. There are also reporting requirements for hospitals that are continuing, specifically around COVID-19's measures that we expect to continue until April of next calendar year. And of course, we require specific reporting from nursing homes to our health and safety networks that the CDC maintains, and those reporting requirements will continue through December 31st of 2024. So again, just kind of an illustration of how most of our waivers and flexibilities around COVID-19 public health emergency have ended, but there are some that are continuing, and we'll talk a little bit specifically about how those, how that timeline will affect our telehealth flexibilities. But you can see on the far right, December 31st, 2024, that's right now the date by which most of the telehealth flexibilities that I'm going to speak to today will end, barring congressional action and or CMS rulemaking or how we write our regulations. So let's dig in. This slide summarizes the temporary changes to telehealth policy that will continue through December 31st, 2024. And specifically, a couple that I want to call out are related to the work that's done in our federally qualified health centers and rural health clinics. These entities can continue to serve as distant site providers for telehealth services that are related to any diagnosis, including non-behavioral and non-mental health telehealth services. Generally, until December 31st, 2024, any clinician who can bill Medicare can bill for telehealth services as well. And there are no geographic site limitations for telehealth services related to any diagnosis, including both non-behavioral and mental health telehealth services, as well as behavioral and mental telehealth services. And the reason I'm making that distinction is related to something in the next slide. Also, until December 31st, 2024, most telehealth services can be provided via audio only under certain circumstances, and we'll get into how you figure out which is which in just a little bit. And telehealth services can be provided by a variety of clinicians who typically cannot provide telehealth services under quote-unquote normal circumstances. These include folks like physical therapists, occupational therapists, etc. So these are the temporary policy changes that will end on December 31st, 2024 as of this moment. This slide summarizes some of the key permanent policy changes that will continue through and past December 2024. That includes federally qualified health centers and rural health clinics being able to provide behavioral and mental health telehealth services through telecommunications technology. So notice the distinction here. The temporary policy is that FQHCs and RHCs can provide and furnish telehealth visits for all diagnoses, including but not limited to behavioral and mental health services. The permanent policy change, however, that will continue after December 2024 is related specifically to telehealth services for behavioral and mental health services only. In addition, Medicare patients can continue to get telehealth services, again, for the diagnosis, evaluation, and management of behavioral and mental health care in their home, and no geographic site restrictions, again, for behavioral and mental health telehealth services. So some distinctions here between the temporary changes I spoke to on the previous slide. Now, this is not specifically telehealth, but I did want to call this out. Acute hospital care at home is an initiative that's been in place for the COVID-19 public health emergency and was also extended by Congress through December of 2024. The reason I mention it is that there are several hospitals in Washington that are providing inpatient level care in Medicare and non-managed Medicaid beneficiaries' homes around the state. And our policies allow hospitals to leverage any number of virtual and telehealth technologies in order to provide that acute inpatient level care. Hospitals must apply or request this capability to actually a team that I co-lead. Once that request is in place, it's reviewed and we ensure that they're meeting all of our non-waived conditions of participation in order to provide care in the home. So if you'd like to learn more, I'm happy to talk with you offline, but you can also take a look at our website that's listed here on the slide. Now, this is a very busy slide, but it brings home a couple of points that I want to make clear as telehealth policy at CMS right now is in flux, and I'll explain why in a minute. But for the purposes of providing these telehealth services, either the ones that are just going to be available through December 2024 or those that are permanently now a part of CMS policy, all telehealth services must be provided via a telecommunications platform that is HIPAA compliant. During the COVID-19 public health emergency, we allowed clinicians to provide telehealth services and we allowed beneficiaries to receive those services via telecommunications technology that was not necessarily HIPAA compliant, such as Skype, FaceTime, etc. But after the COVID-19 public health emergency, the HIPAA compliance rules are now reinstated. There was a 90-day grace period that ended on August 9th, clinicians having a 90-day transition time to get their HIPAA-compliant telecommunications technology up and running. But now, as of August 9th of this year, we do require that any telehealth service that's provided must be provided via that HIPAA-compliant telecommunications technology. And the details of those HIPAA rules, while not controlled by CMS, are a part of our requirements. Congress also has acted to allow CMS additional flexibility to extend telehealth policy past the public health emergency. And as I spoke to on the previous slides, there's a number of policies that continue through December 31st of 2024. The center of this slide really just kind of summarizes that information in a different way. So regarding patient location, telehealth services may be provided to Medicare patients in any location in the United States. They can be in their home, they can be on this, at school, they can be in a medical office, they can be in a hospital, they can be in a parking lot. Doesn't matter where the beneficiary is, telehealth services can be provided to that person regardless of their location. In addition, as I mentioned earlier, CMS has greatly expanded the number and the types of telehealth services that can be provided, and we keep that list on what's called the Medicare Telehealth Services List, the link to which is on this slide. We will continue to maintain that expanded list of telehealth services that are covered and reimbursed through December 31st of 2024. And on this list is where you will find the designation of which services can be provided via audio-video only and which services can also be provided via an audio-only or telephone communications technology. In addition, as I mentioned before, through December 31st of 2024, generally any clinician who is eligible to bill for Medicare services can bill for telehealth services during this period. And of course, on the Medicaid side of things, coverage for telehealth services varies from state to state, but Washington has quite a robust telehealth policy in place. And of course, CMS also provides guidance to states about how to update their telehealth policies in their state plan amendments. One of the other things, I know there's lots of questions about reimbursement for telehealth services, so the last bullet point on this slide is quite important. Telehealth services that are provided in the office setting will continue to be paid at the non-facility rate, which is the higher payment rate, through the end of calendar year 2023. Now, all that being said, I'm going to make a couple of caveats and then talk about some of our proposed policies, which may very well change what I had on that slide. But first, let's take a look at the example of the Medicare Telehealth Services List. If you're not familiar with this list, I highly recommend popping over to that link on the bottom. You'll see a huge spreadsheet of code after code after code. So this is really just a snapshot of a couple of services that are on this list right now. Things like initial nursing facility visits, home visits for new and established patients, etc. Again, on this list is where you will find the services that are designated as can only be provided via audio-video technology, and you'll find the list of codes that can be provided via AV technology and audio or telephone only. So this is the place to find that information if you're looking for it. And of course, again, as I mentioned, for Medicaid and the Children's Health Insurance Program, telehealth flexibilities are actually not tied to the public health emergency. And like Washington State and many others, states have been providing telehealth services in their Medicaid programs for many, many years. So ultimately, on the Medicaid side of things, the state is the ultimate authority in partnership with CMS. Now let's talk a little bit about some of our proposed policies that may very well affect telehealth policy at CMS in the coming calendar year. Many of you are probably familiar with the way that CMS makes regulations in what we call our proposed rules cycle, where we put out our proposed policies, they're available for public comment, and then many months later we publish the final rule which governs our reimbursement and regulatory policy for the coming calendar year. And that's the physician fee schedule, among many other regulations. So while the public comment period for the physician fee schedule for next year has ended, it ended on September 11th, I still do want to point out a couple of our proposed policies, and you can find it all summarized at the link on the bottom of this slide. There are a number of topics in the physician fee schedule proposed rule, and we don't have time to go through all of them, but I am going to speak specifically to the telehealth services proposals, and happy to follow up if you have questions on any of the other items. So, a couple of busy slides here, but I'm going to try to distill it down for you. As I mentioned, during the COVID-19 public health emergency, CMS greatly expanded the number of services that can be provided via telehealth on our Medicare telehealth services list. For calendar year 2024, CMS has proposed to add to that list health and well-being coaching services, as well as social determinants of health risk assessments. We are also proposing to implement several additional telehealth provisions that Congress enumerated in their legislation from 2023, and that includes expanding the scope of telehealth originating sites for services furnished via telehealth to any site in the United States where the beneficiary is located. So that would potentially change some of the information I presented on previous slides. So I know this is a sort of a point of confusion for a lot of folks. These policies are not yet finalized. So this policy may or may not happen, depends on what the final rule is set, and that will happen later this fall. But if this policy is finalized, it will mean that there is no sort of geographic restriction for beneficiaries accessing telehealth services, regardless of the diagnosis for which they're being provided those services. We've also proposed to expand our definition of clinicians who can provide telehealth to include qualified occupational therapists, physical therapists, speech-language pathologists, and audiologists, folks who have been providing telehealth services for the past 3 years under our regulatory flexibilities for COVID-19, but for whom, under quote-unquote normal circumstances, they actually are not allowed to provide those telehealth services. So we're proposing a change to our policy on a permanent basis that would allow these folks to continue doing what they have been doing, and what we've learned is working quite well. So again, this is a proposed policy. Should it become finalized, you'll see it published in the fall. We've also proposed to continue payment for telehealth services furnished by rural health clinics and FQHCs using the methodology that we established during the public health emergency. And for rural health clinics and FQHCs, the next bullet, quite important as well, delaying the requirement that we have in place that someone be seen in person within the first 6 months of receiving a telehealth service related to their mental health diagnosis. So lots of proposed changes here that may very well impact our current telehealth policies as it stands and as I've spoken to on previous slides. We've also, again, proposed to continue covering and paying for telehealth services that are on the telehealth services list until December 31st of 2024. A couple of other things that I do want to highlight. We have proposed that beginning in calendar year 2024, telehealth services furnished to people in their homes would be paid at the non-facility physician fee schedule rate. Again, that's the higher rate. And we're doing so in order to, or we're proposing to do so in order to protect access to mental health and other telehealth services, to, in other words, align our reimbursement policies with other telehealth related flexibilities. We've also proposed to continue to allow clinicians who are supervising trainees and or other clinicians the ability to be readily available via audio-video technology through December 31st of 2024. That was a policy that was put into place during the COVID-19 public health emergency. We're proposing to continue that until December of 2024, but we've also asked for comment about whether or not that should be a permanent change, and specifically focused on people's assessments of patient safety under these kinds of arrangements and quality as well. And then keeping in the theme of direct supervision for those clinicians who are supervising resident trainees, we have proposed to continue allow teaching physicians to use audio-video real-time technology to be present for those key parts of the exam where the resident is furnishing Medicare telehealth services. And of course, we saw a comment as well there around patient safety, quality concerns that folks might have, teaching-related concerns as well. So lots of comments were brought in to CMS over the course of our 60-day public comment period on these and other policies. We're in the process of sorting through all of those right now. So that was a snapshot of where we're at with CMS telehealth policy. And these resources I do want to point out to you because things are continuing to change as new legislation gets passed and of course as our proposed rules then become final rules this fall, you very well may see some additional changes. So a good idea to bookmark the Medicare telehealth services list, which is here on the slide, as well as tips for billing telehealth. That's the second to last link on the slide, as well as our telehealth providers toolkit, which has a lot of really good tips and tricks around coding and modifiers, etc. So with that, I will say thank you very much for your kind attention. Happy to follow up on key details when we get to the Q&A portion. But of course, if you have any CMS-related questions and you can't find what you're looking for, please don't hesitate to reach out to me. My email is here, and I'm happy to follow up with you. So thanks very much.
And hi everyone, good morning. My name is Christopher Chen. I am an internist and I work as a medical director for Medicaid at the Washington State Healthcare Authority. It's nice to be out here in Wenatchee this morning. It was a lovely drive over from Seattle. And so I'm just here today to give you a little bit of a policy update on telehealth for Washington State Apple Health Medicaid. And just kind of as a reorientation to Healthcare Authority in case some of you aren't familiar with our agency. We are one of 4 Health and Human Services agencies for the state of Washington. Our sister agencies being the Department of Health, the Department of Children, Youth, and Families, and the Department of Social and Human Services. The Healthcare Authority wears a number of hats. We're a public purchaser, we're a behavioral health administration, we're a health IT agency, and we're also a Medicaid agency, of course. And so today, speaking on behalf of our role as a Medicaid agency, but kind of covering both the commercial and the Medicaid side, we do cover more than 2.5 million Washingtonians. These are the MCOs that we work with. So managed care covers about 85% of our Medicaid population. Medicaid running around 2 million enrolled individuals. And 15% of our clients have their benefits directly managed by the Healthcare Authority or dual covered by Medicare. And so kind of hearkening back to 2019 and the pre-pandemic state of telehealth. So Washington has been fortunate to always have had been an innovator in the telehealth space. And we've had broadly flexible policy that's been applicable to many types of services and providers in different settings. So patients could be located in a number of places, providers could be located in a number of places, and we had a pretty flexible policy in terms of what services could be provided via audio-visual technology. Telemedicine payment parity has been in place as well since 2018. And the Healthcare Authority has been regularly engaging with partners in the community, even before the pandemic, including through forums like the Telehealth Collaborative. So during the pandemic, the agency made a number of updates to telehealth policies to support access and continuity of care during that crisis. We also provided more direct support for providers and patients, and some of you may have heard about the Zoom license program. We issued about 2,000 Zoom licenses free of charge to providers who needed them, and were serving predominantly Medicaid patients. And that program has been pretty successful. We've had a number of providers, including behavioral health providers, utilize our Zoom license program. We also distributed a number of laptops and phones to provide that direct hardware support for providers who needed that. And sorry, on that phones, our Medicaid clients also have access to cell phones through the Lifeline program through the MCOs, and kind of ongoing collaboration with our partners in telehealth. So currently, the state of telehealth policies, so we continue to cover real-time audio-visual, and as Dr. Wolfe referenced, there was a temporary kind of flexibility in terms of HIPAA compliance. We do expect everyone to be using HIPAA-compliant telehealth technology at this time, and so real-time audio-visual telemedicine continues to be defined as such. Audio-only services coverage was initiated at the pandemic and kind of enshrined in statute with House Bill 1196 in 2021. And so we have our audio-only services that are allowable posted on the website. There's a list of services similar to how Medicare has posted those. We cover e-consults. We have a long history of covering store and forward technology back to, I think, 2015 in Washington, and that was kind of formalized through the pandemic. And so we do cover e-consult services, which I know can be very helpful in rural primary care practices, and we've seen a good uptake in that service. And as of October 21st, are going to be covering both the 99451 and 452 codes to recognize both the specialist and the primary care provider's effort in managing that information. Remote patient monitoring is covered as well. Can be helpful for monitoring individuals with heart disease or hypertension in remote settings to keep an eye on their vitals. Store and For video is kind of a newer one that is covered. Patient portal visits and remote check-ins. And as far as evaluation goes, this is more specific to audio-only services. The Healthcare Authority is very interested in ensuring access to high-quality care.